So how do we do basic workup of infertility? We all know that the prevalence of infertility in India is not ranging between 3.9 to 12.6. It is much more than this. It is much more. And after COVID, it has really increased. So how to go about? Look, so many times we can only a good examination and seeing the patient once she enters, we know how to go about. For example, these are two types of patients. And I know as soon as I get a patient like this, who's an oldie, that even if she doesn't want to go for IVF, if she's around 40, we have no time to lose. Probably she should go for IVF, whatever eggs she's got, we have to utilize them. One thing which I want to share to you, we all know that the fertility declines after the age of 35 years. The Indian women have menopause 5 to 6 years earlier than the Western world. In fact, the Asian women. So we have to learn to take action as soon as possible. We've already talked about the carrying angle, the web neck. So we have to keep our eyes open once the patient is entering. This boy is typically looking like hypoandrogenism. PCOS we know. So we have to see these features because so many times a patient enters my OPD clinic and the first question which I ask her is, what is your menstrual cycle? How often do you have it? कितने महीने बाद आते हैं? I mean, because I know it that she is a case of hypomenorrhea, oligomenorrhea. So menstrual history is important. Any history of overdue periods. How is the periods like? I have already talked about the importance of temperature in a clinic who's doing infertility practice. ESR again is very important. Sometimes I see a rise of ESR from a low level to a high level. Again, it gives me a reason to think that what should I be doing? TVS, I always call it is like a pen for an infertility specialist. For example, even if you people are not doing your scans by yourself, the first step of practicing infertility is start putting a TVS probe. How I started my practice was, प्रहलाद ये आ रहा है, ये हट सकता है यहाँ पे because ये फिर presentation में खराब हो जाएगा. Okay. So how I started doing my TVS when I started my practice was, I used to send all my infertility patients to the radiologist for a TVS scan. But when they would come back, I would tell them, let me see it by myself. I won't charge you, but let me see it by myself. And this is how I learned. And I always tell people, the more you will put TVS scan, the more you learn. It's very easy. As compared to an abdominal scan, it is very easy. But the more you do, the more you learn. Thyroid and prolactin, I've already talked that it is really important to get thyroid and prolactin done. Now, as an infertility specialist, any TSH more than 2.5 should be treated, right? Number two, if the TSH is anywhere between 2.5 to 6.7, I would just treat her by 12.5 L-troxin. The medicine for thyroid should be taken empty stomach. It is like hit and try as well. Usually, my policy is if somebody's TSH is 50. I know it will click somewhere around 50, the dose of L-troxin, but it is obviously hit and try. Once you start giving L-troxin, you can call her after 1.5 months and see that if she is in your range or not. And you can titrate. Thoda sa increase and a little bit decrease is absolutely onto you. Number 2, as far as prolactin is concerned, we have to understand that prolactin is an emotional hormone, right? Why do people secrete prolactin when the baby feeds? So the prolactin is secreted by the pituitary, yes, by the pituitary, and this will help in milk release. So if we do one sample of prolactin, the results might not come normal. I have seen prolactin as high as 180, but the next day when I did, the prolactin was absolutely normal. So one recommendation as an infertility specialist is that do a pooled sample. Patient does not have to pay for the 3 samples. You have to take 3 samples, or your lab person is instructed to take 3 samples at an interval of 1 hour, so that if there is an emotional element in one sample, by the time second and third sample comes, it's mixed and we get the average result. So this is one recommendation. Now people will ask me a question, what is my preference, bromocriptine or cabergoline? I love to give cabergoline because it's very easy to give. Wednesday, Sunday schedule is very easy. But when do I add bromocriptine in my practice? Number 1, if suppose the prolactin is very high, I have seen really high prolactins, approximately 400 as well. So I usually like to top up with bromocriptine. I don't know if there is any rule or any policy, but this has been in my practice that for initial 15 days, 20 days or a month, I add the bromocriptine, and I like to keep her with cabergoline. When do I stop cabergoline? When she's pregnant? Usually the studies and the recommendation is to stop once the patient is pregnant, because after pregnancy her prolactin is going to rise as it is. But somehow I usually take it till cardiac activity. Semen analysis, again, it's very important as a basic workup. But I told you yesterday also that it is not just the semen analysis we do. We also do the culture simultaneously in the first visit itself. In fact, to tell you, our center has got a machine to test the semen, which is a very interesting machine. We put a drop of the semen sample on it, and the result comes on the screen. It's an AI. The AI is put into it and the results come within a minute. The best part about it is it's so easy to explain it to patients that what her semen report is like, because otherwise they are just getting pages and pages and pages of so many reports and they don't know. And usually we as infertility consultant also see just the reports. We don't see the sample ourselves. So I love this. I'll like to share 1 or 2 videos tomorrow with you before I start the PCOS discussion. So I like it. And what more I like about this machine or this technology is that it also tells about the morphology of the sperms. The WHO recommends that at least 4% of the sperms should be normal morphology. That is, out of every 100 sperms, at least 4 should be normal. So this report also tells about the morphology. So now coming to the next slide. We have already talked about the male infertility, what every gynecologist must know, but still, that day I had to rush through some of my interesting slides, so I would take a pause. And naturally, the first examination we are doing to check if the male is normal or not is the semen examination. We get three types of scenarios. Number one, a very good count and motility. Number two, not so good count, but something is there and they are not very active as well. And the third scenario is azoospermia. I want to say that a very good count and motility excludes out a male only in 90% cases. It is not that a good count and motility is a sure shot indication that the male is fertile, because there are so many times acrosomal defects which is affecting the egg penetration. So, this sure shot confirmation that the male is fertile is number one, if the wife is pregnant. Number two, if we see fertilization in IVF. So we can't guarantee every male that he is not responsible for infertility. Lots of cases of unexplained infertility where we have worked up and we are seeing that the girl is normal, that the male is normal, but still they are not getting pregnant. So many times the male is responsible. Number two, situation where the count and motility is not so good. Now, what do? I do lifestyle modification. I really take a lot of time in explaining to patient that how much lifestyle modification has a role. Do I give antioxidants? Yes, I do give antioxidant to my patient, but lately I have started recommending them Chyawanprash as well. The constituents in it really have wonderful effect on male fertility. Number two, in such a case, I will always see at the culture, because I already told you that the subtle infection of the semen is responsible for DNA fragmentation, spoiling the sperms and making it effective. So this is number two. If I'll remember something, I'll share with you. And the third situation was azoospermia. We have already discussed very nicely yesterday itself. But still, I want to revise male fertility panel for all azoospermias, in which FSH is most important. If the serum FSH is more than 15, this patient requires a donor semen sample from a good donor bank. Here again, I want to tell you, we are running a very nice donor bank. If in any case, any of you want semen, so you can ask for it, or you can send your patients to us just on the day of IUI. We can do an insemination, because in today's scenario, not everybody should do IUI until and unless your center is ART1 recommended. So it's no longer the practice that used to be there years back, when every gynecologist would do IUI just like that. No, we have to take care. We have to follow rules, because maybe no problem comes today, but 20 years after, suppose that there is some problem between husband and wife and they sue against each other, you will unnecessarily come into their trap. So if the FSH is less than 50, it means that there is normal spermatogenesis. Ideally, yes, you should refer this patient to IVF centers so that we can see that it is some blockage, because in such cases, IVF is required. What do we do in ICSI? We'll be sharing a short video, or we'll be posting in the group that how do we do ICSI. In ICSI, what is the difference between IVF and ICSI? I'll take just a moment to discuss that. In IVF, we collect the eggs and we put sperms in it for natural fertilization. This is called in vitro fertilization. It is happening inside the lab, inside the incubators. Now, in ICSI, one egg is picked up and one sperm is inserted in it. So I'll be sharing a real video today only in the group, and whatever I'm saying, if I'm forgetting something, please do message so that our team can take care. So this is called ICSI. Now what is PISA? In PISA, there is percutaneous needle. I mean, the needle goes from the groin area to the epididymis and we aspirate the fluid in it. Where is it required? It is required in the cases where there is a blockage, the epididymal blockage. It could be congenital or it could be secondary, so some infection of the male. So in PISA, we are going to take out the sperms, see them under microscope, and we do it at the time of pickup. So here we are collecting the eggs. Once the pickup is done, the embryologist or the urologist or the surgeon will aspirate the sperm sample from the male, and then these sperms are going to be used to inseminate, to do ICSI. So this is called PISA. What is TISA? In TISA, we put a needle directly into the scrotum, into the testes, and aspirate the sperms. But what is the difference between PISA and TISA? In PISA, we will get the motile sperms, the mature sperms which have left the testes. But in TISA, so many times we will not get mature sperms. So we prefer PISA rather than TISA. Low count and motility. So oxidative stress is very important, which is leading to high sperm DNA fragmentation. And this is responsible for 30% of unexplained infertility and also cases of recurrent abortions. When I'll be taking the class of recurrent abortion, I'll be telling you that 50% times the male is responsible. So once we are treating a patient of recurrent abortions, we are just not allowed only to take care of the lady or think about the factors which are affecting only the female. Yes, oral antioxidants do have a role in bringing the live birth and pregnancy. Okay, so this is again, although I did touch about this topic yesterday, but the male genital tract infections, subclinical. What do I mean by the word subclinical? Clinical is when the male comes to you or to a surgeon with a problem. He comes with a complaint of prostatitis or some pain while passing urine or recurrent UTI. So this is clinical male genital tract infection. But a subclinical male genital tract infection is when the male doesn't know absolutely that there is any problem or not, but it is you who are going to pick up. So here I wanted to tell, although I did talk about it yesterday, that you are not just allowed to see the bacterial infection. We have to take care of the virus infection as well. And one more very important thing is the protozoal infection as well. So it's not a bad idea to give the kit which we give to the lady, to the male as well, when we are trying to treat the infection in a broad spectrum way. So besides semen culture, another test is semen PCR for tuberculosis. Since I always am on a lookout for the females who got tuberculosis, I also have to see what is the cause of their tuberculosis. Has it come from, the respiratory tract? Has it come from the blood? Or has it ascended from the semen? So semen PCR for tuberculosis is again very important, which you can make out which patients to get. I mean, the patient will have a low count and motility, but the patient would also not look so active and healthy. There could be temperature rise in male as well. So always keep in mind that semen culture plus semen PCR. So whenever we are treating any subclinical infection, it's not just the antibiotics we should give, we should also give antioxidant. And again, males require antibiotics for a longer time. We have discussed the normal menstruation in detail. Now, as I told you, I would like to show you the photographs. How does a ovary look on TVS? Though in this diagram, the silent ovaries, what you are seeing, are typically PCOS ovaries. This we specially included to tell you how antral follicle look like. Whenever we are doing a scan on day 2, we want to see silent ovaries. That is, there should be no cyst any side. Sometimes what we see is there is a cyst, not very big, but a small cyst, let's say 2 centimeter. Usually it is the residual corpus luteum. At times, I would call the patient after 2-3 days and check if it has gone or not. If it has not gone, then I would try to take a break cycle and give her on any OC pill or something so that by next cycle, this is not seen. So on day 2, we want to see silent ovaries. Number 2, you also have to count the antral follicles. We call them antral follicles, these small bubble-like things, because this is going to help you to plan your action. And at the level of the endometrium, we want to see thin endometrium. Day 2, day 3, we expect that the endometrium has already shed. So it's like a new beginning. Suppose if the endometrium is still thickened, what does it mean? It means that there hasn't been adequate progesteronization, which we see very commonly in PCOS patients. So, what am I going to do if the situation is not like this on day 2? I've already told if I see a cyst or a residual corpus luteum, I'm going to take a gap cycle before I do ovulation induction. If I don't see thin endometrium, again, I'm not going to start stimulation. So this cycle, I would like to give her progesterone. Usually, I like to give primoluten, ciceron, and kind of a thing. If it is very thick, then dosage even 2 times PD for 24 days is required. Once it is withdrawn, she will bleed nicely, and next cycle, you will see a thin endometrium. But suppose even after giving her progesterone for 2-3 cycles, you have not found thin endometrium. What does it mean? Number 1, it could be a space-occupying lesion inside the uterus. Maybe we are dealing with a polyp or something which we are missing out. Number 2, if the patient is not properly downregulated with progesterone withdrawal, I like to give injection TPO. the leupride depot, the 3.75, which you people must be using in cases of endometriosis very commonly. How do I give it? In a normal cycle, I usually like to give it in the secretory phase. And even after the withdrawal of leupride depot, if she is not showing a thin endometrium, that means we are missing on something. There is definitely something in the endometrial cavity. Or it is an adenomyotic uterus, and what we are looking at is a fake trilaminar look or fake thickened endometrium in the myometrium. We are not looking into the uterus. Okay, so on day 12 of your stimulation, just to tell that my favorite is letrozole. In my normal protocol, I like to give 1 BD for 5 to 10 days. I'll tell you why I give for 10 days and in which patients I like to give for 10 days. But once I have given it for 10 days, I like to do a TVS scan on day 12, and a mature follicle would look something like this. And this is typical trilaminar endometrium, very beautiful. I hope you can appreciate the endometrium between the blue plus sign. So this is what I want to see. If such is the situation, I would plan the HCG injection and will ask her to have contact from the day of HCG itself for coming 3 days, and after that we give her progesterone support. Again, sharing with you some images of the endometrium. On the top, it is the day 2 endometrium, day 2 or day 3, where it's a thin endometrial line. Mid-cycle, just prior to ovulation, it's a trilaminar endometrium, and the lowermost picture is showing of the secretory endometrium. It's a little bit glassy or hazy endometrium. The same triple line as if has gone a little bit hazy. You can still see the 3 lines in it, but it is more homogeneous now and it is slightly more thickened. I told you that it's not that clomiphene has got out of my practice. After 2-3 stimulations with letrozole, I do like to try with clomiphene citrate. Clomiphene citrate, how does it act? It is a selective estrogen receptor modulator, so it will act on the hypothalamus and will increase GnRH, will increase FSH, and this is going to act on the ovary to cause folliculogenesis. But one bad effect it does is, since it is blocking the estrogen receptors, the cervical mucus will not be good enough, the vagina is dry, and the endometrium is not very good. But since I told you that I still like to use it after 2-3 failed cycles of letrozole, because usually clomiphene citrate does not affect the endometrium in the first cycle itself, but if somebody is using clomiphene after clomiphene, the endometrium is getting disturbed and the cervical mucus is also getting disturbed. So at least, even if you're fond of clomiphene citrate, don't use it cycle after cycle. So how should you use? Although the dose here is 50 mg, sometimes when I am doing minimal IVF for my patients who cannot afford a proper IVF cycle, I add clomiphene citrate along with the injections. The injections are usually not at a very high dose, sometimes even 75 international units of HMG, but then I would like to add clomiphene citrate with it to produce more follicles. So then in that situation, I would give it till the end. And in that situation, I usually use 100 mg dose, but not for 5 days, till the end. Now, when medical representatives come to you, they tell you that, you can start clomiphene citrate from day 2, day 3, day 4, and even up to day 5. If you are using clomiphene citrate from day 5 of cycle, it is going to help you in the next cycle to form more follicles. It's got a long half-life. So in cycles where you're planning something in your next cycle, you can just give clomiphene citrate, planning for your next cycle. Okay. When do I like to change my protocol? Usually I'm a person who believes that you have to hit and try because all the patients are different. So whatever you're doing in one cycle, and if it is not working and you've done it for second cycle, just try and change your protocol. When do I like to do laparoscopic ovarian drilling? Again, I'll be talking about it in great deal tomorrow when I'll be discussing PCOS. Do I give combination of clomiphene citrate and gonadotropin? Yes, you people can try if clomiphene is your favorite. I do give combination of letrozole with injections. So metformin, I purposely left it because we are going to discuss it in detail in the PCOS session. So letrozole, we all know, rise, fall, and rise again. It's really a nice drug. Why do I like it over clomiphene citrate? Number one, it helps in usually monofollicular development rather than multifollicular development. The endometrium is not harmed. The cervical mucus is good, but since I was telling that I give letrozole in two different, in not two different protocols, but in lots of different styles. I have given letrozole, all the 5 tablets on day 2, all of them together, and then no letrozole. Number 1. My most favorite is starting on day 2 till 5 days. Number 3. At times, I've told you, I give for a period of 10 days. Why? Because letrozole does not let the premature LH surge to happen. So it keeps the progesterone level low during the cycle when you don't want progesterone. We all love progesterone. As an obstetrician, as a gynecologist, progesterone is our favorite. But for a fertility patient, we want the progesterone to come only after ovulation. So letrozole helps there. So yes, it has got a short half-life and it also helps in increasing the blood flow, uterine blood flow.